Hello, Lyle, and hello, listeners. My name is Nadia Kadam. I'm a neuroradiologist, and I'm here with a medical student, Lyle Saar. Can you introduce yourself?
Of course. My name is Lyle Soda. I'm a fourth year medical student at UMass, and I'm working with Dr. Kadam on quality improvement projects. And this is one of the most exciting projects. So glad to be here, and hopefully, this is helpful.
Okay, I'm sure it will be. Our topic today, as we walk through the ABR non-interpretive skills syllabus, is a core concept of safety. Did you read through the chapter, Lyle?
Absolutely.
Okay. You might be more prepared than I am. So they're referring to two reports here, and they're really landmark reports. Both of them are from the IOM, Institute of Medicine. Now it's the National Academy of Medicine that has taken over. And so one report was published in the year 2000, To Err is Human, and the other one came out in 2015, and it was improving diagnosis in healthcare. So that might show up on exams or some factoids that are important to know. But these are really landmark publications. Do you remember what the most important messages were from the 2000 IOM report, To Err is Human?
Yes. So the biggest distinguishing thing between the 2000 report and the 2015 is the 2000 report main focus is on medical errors broadly. And they defined it very distinctively that medical error is a failure of a planned action to be completed as intended. So it had good intent, but it wasn't completed properly. And the second definition was that the intention or the plan itself was completely wrong to achieve the aim that they wanted to. So they provided us with the definition, and they defined that the highest risk of errors occurs as expected in the highest acuity environments.
Wait,
And
and then how's that different from the definition that they gave in 2015? They updated that definition.
yep, so they narrowed it down more from what I could tell because the 2015 focused on diagnostic errors specifically. So they said it's a failure to establish accurate and timely explanation of the patient's issues, problems. And then the second part of it was the error in not communicating that explanation to the patient. So diagnosing and then communicating.
Yeah, that was a great summary. I think that was a big leap to add in the communication of the results to the patients, because previously we hadn't considered that the patient can take ownership of their own care and make sure that these errors don't happen. So we do have communication gaps sometimes. Our reports don't arrive or aren't noticed by the receiving provider. So if the patient knows about the results and knows that there's follow-up needed, they're another safety net for themselves. Do you remember in that first report, they threw out some numbers of how many patients we kill in healthcare annually from avoidable errors? Do you remember those numbers?
Yes.
Avoidable medical errors. So the number that they gave was between 44,000 and 98,000. So it's a little bit baffling that it's so inaccurate. That's quite a range from 44 to 98,000, but subsequent publications have said it could be as high as 250,000 patients per year. So it's hard to get accurate data. You could argue even one person that we kill from an avoidable error is too much, right? So 44,000 or 250,000 is way too much. So that was the first time in healthcare that we became aware that we're not only helping people, but we're also killing people. It was very shocking. And
Yeah.
people turn to other industries to see how they're practicing very safely and what we can adopt from their practices. And we'll go over that in a little bit. They talked about some of the fundamental factors that lead to errors in that IOM report from 2000, To Err is Human. And there were three things that they mentioned. Do you remember what those three things were?
Think the first thing was a systematic issue. So the word they use here is decentralized nature of healthcare delivery system. So when it's a non-system, it becomes an issue. The second one is the failure of the licensing system to focus on errors. And then the third is impediment of the liability system to identify errors. I guess that kind of gets split into another one is failure of the third party providers to provide financial incentives to improve safety.
Decentralized healthcare delivery to me means that there is not one entity that has all the overviews. Sometimes patients have different providers for different things, and they're not necessarily under the same system. For example, I work at a university right now, and if we have patients come to our center, our system, we have all their records so we can see their labs, all their clinic visits, their imaging, everything. But if they go to a provider that's outside of the healthcare system, we cannot see that information. They could have additional imaging and labs somewhere else that we don't know about. So the fact that there is not one unified overview is a problem. And there is legislation in place to help these electronic record systems to talk to each other, but it's not been implemented in the way it was intended. So that's a problem.
Sure.
The failure of licensing systems to focus on error. To get a medical license, that is something I get in the state that I practice, and then I get credentialed by my institution. And I get certified by my board. So there are all these different terms: licensing, credentialing, and certifying. The impediment of the liability system to identify errors. That's a very important and very interesting one. So it means we have internally a desire to report errors so that we can learn from errors. That actually contributes to a higher safety culture. But the medical legal system is set up to punish errors. When you're afraid of punishment, you don't want to report an error. So it's the opposite effect. And that's what they mean by impediment of the liability system to identify errors. People are afraid to disclose errors because they're afraid of a medical legal action. And that's why we have risk management people at our hospital. They try to mitigate errors, work with patients who suffered from errors, and avoid medical legal action through settlements and other things. But it's a real problem still. People are afraid to identify errors. And then the fourth part was the failure of third-party providers to provide financial incentive to improve safety. That is actually improving. So the third-party payers, in other words, are the insurers, so any private insurance or CMS. And they are increasingly looking into ways to incentivize safer practice. So there is some movement afoot for that. Okay, great. So what they found out in this first IAM report is that committing errors is human. We all make errors. It's unavoidable. You just have to accept the fact. And the best we can do is learn from our errors. This actually was a landmark shift from blaming people and firing people for an error to understanding that they may not have done something intentionally. And this is where the just culture comes into play, which we'll talk about in a minute. In the second report, they actually throw out some numbers. Do you recall how many Americans or how many postmortem exams had a diagnostic error?
They mention it broadly that all Americans will, in their lifetime, experience a diagnostic error that's meaningful. And then I think the specific number, average 10% of postmortem exams were associated with diagnostic errors that might have affected the outcomes of the patient. So that is
That's true.
significant.
Yeah, 10% is quite a bit. And then it said of the people they surveyed, 1 in 6 already had experienced the diagnostic error. So it's quite prevalent. All right, good. So the recommendations that were made were non-punitive actions, learning from errors, and then being collaborative, often between different professionals and professional groups, because the systems we practice in are so complex. You can't solve problems on your own. You have to have all the players involved to help solve problems. There were 8 specific recommendations for improvement. Let's go over them. Do you know what the first one was?
Effective teamwork. So in line with the report emphasizing collaboration, it makes sense that they start off with emphasizing everyone that kind of has a role in the patient's care needs to be aware of it. So effective teamwork.
Perfect. And the patients and their families are part of that team. That's also important.
Yeah.
What was the second one?
It's education and training. So incorporating a way to teach and train people to implement and learn about these processes, I think.
Yeah, that seems so obvious because diagnostic error can be related to the fact that you haven't learned something, you make a finding and you interpret it the wrong way. But it's more likely that we actually miss a finding because we're distracted. Like just when we're at that image with the finding, the phone rings or somebody distracts us. And there is a number of other factors. There's actually a whole litany of diagnostic errors for radiologists. So there are cognitive errors and non-cognitive errors. So it's interesting to study those. Then what's the next one?
It's health information technologies and making sure that is supporting patients and professionals.
Yeah. So if we're talking about sharing results with patients, it's good to have portal access for patients, for example, and then making sure that all the providers get the reports appropriately. Okay. What's the number 4?
Emphasizing organizational approaches. So, not individuals, not small groups, but having the whole organization on board and in line with objectives is important.
So when you're in a radiology practice that's not affiliated with a hospital or a university, you may need to institute as an organization, quote unquote, your own system for evaluating errors. So usually there should be a system to report an error, and there should be people who analyze these errors and find the root cause and then fix the system. Like me, I'm in an academic center, so we do have at the system level, we have a risk management department, we have reporting systems and people who manage those errors that have been reported. What's number 5 out of 8?
I think you started touching upon it. Is fifth one is work systems and cultures that support diagnostic processes, taking the organizational approach and making definitive systems in the workplace and creating a culture that actively promotes and allows for proper processes and diagnostic errors to be identified and learned from.
Yeah. The work system overlaps with what we just talked about, but then the culture is also a big piece. I think the culture in many radiology practices is more about high volumes and a lot of RVUs that can be reimbursed and not so much on really providing safe care. So that's important to raise that awareness that culture is crucial. Then number 6.
Reporting. So when things occur, when things happen, allowing people to have the motivation to report and having a system that takes that reporting and processes it properly. I think the whole realm of reporting.
Yeah. And then addressing this medical liability system that interferes with our reporting. And then number 7.
It's payment and care delivery environment. So making that environment or delivery system that supports the process. It says here specifically oversight bodies should require that healthcare organizations have programs in place to monitor the diagnostic process, identify, learn from, and reduce diagnostic errors or near misses.
Yeah. So we have one example of an oversight body is the Joint Commission. They come unannounced, visit your place of practice and examine. They have a whole long checklist of things that they're looking for, whether you have policies in place and your policies are updated and you store your medications safely and they're not expired and things like that. They also make sure that you have peer performance assessment tools in place and peer evaluations in place. So it's very important to drive that safety culture. The last one is provide dedicated funding for research on the diagnostic process and diagnostic errors. All right. And then there were a few more recommendations from the 2015 IOM report that were specific to radiology. I think they have 4 basic recommendations. Do you remember what those were?
These were specifically trying to address improving quality of communication. The first recommendation was standardizing communication policies and standardized definitions that are used across the organizations that are in network. I think that's a really big buzzword even now and has been standardization of and everything. That was the first one. The second one was ensuring clear identification of the patient's care team. We need to know who to alert, who to communicate with. Like when you click on the patient, it lists out all the providers involved. So I think that's a big factor to consider. The third one was implementing effective result management and tracking processes. So I think Dr. Kadam knows a lot about incidental findings and how that gets tracked. But even in breast radiology, when things are identified, it automatically gets put into a system and automatically gets tracked throughout time and sends alerts to patients. So I think that is important. And the fourth is developing a shared quality and reporting metric. So we all talk about improving or bad, good, but we don't have any specific things we're measuring. Developing a good quality measuring system to
Yeah, good. That was excellent. There's very little that I can add, although you know that I can ramble for a long time. The standardized communication policies, one example for that is critical result reporting. Everybody needs to have a policy for timely critical results reporting that's mandated for the Joint Commission. So most people have a policy saying that critical results need to be reported within 60 minutes or so from the finding discovery to the verbal report. And it has to be a verbal report and it has to be documented in the radiology report. So that's an example of standardizing communication policies. Some people have more policies where they go further. In addition to critical results, they also define urgent results and actionable incidental findings. The patient identification is interesting. We take the patient's information when they sign in at the front desk or when they first sign up for that healthcare system, and it could be outdated or inaccurate because it's typed in by a clerk. It could be a typo that sometimes isn't accurate, and we haven't quite found a way to verify that. And for the providers, it's even worse. We often have providers in the system from 10 years ago, and now they've since stopped working for a particular group and moved somewhere else, and we don't have updated information. It can be very frustrating to try to get a hold of somebody with an important result. We do have reading room assistants that help us getting in contact, and we pull all the strings. We look up people on the internet, on social media, trying to get in contact with them. And the last resort is always just notifying the patient themselves, especially when it's a critical result. Yeah, you gave a great example for tracking processes like mammography. That's perfect. That's the picture book tracking system. And that can also be used for actionable incidental findings. So if there's incidentally a lung nodule on a trauma CT that looks like it could be cancer, that patient should also be tracked to make sure that whatever follow-up imaging we recommend gets completed and catch that cancer if we can. The shared quality and reporting metrics, that's a very broad recommendation. I think everybody's trying to have quality metrics. I'm not sure that they're shared nationally very broadly, but we do have quality metrics. So an example could be appropriate use of evidence-based follow-up recommendations. So if you can track something like that, would be a quality and reporting metric. And we do track the timeliness of critical result reporting. And then everybody tracks the turnaround time. So the time from when the exam is complete until the radiologist finalizes the report, because we want to make sure that it's overall timely.
yes.
Good. Okay, we covered a lot. Let's end it here for this topic, and then we're going to continue with another session talking about human factors and just culture. Thank you so much, Lyle.
Of course.